As we age, our bodies and priorities change. So should our medication management, which is why we may look to reduce medication burden. What was appropriate treatment for someone at the age of 65 likely needs to be adjusted when they're 85. There are many reasons for this, including physiologic changes that increase our chance for adverse drug events, including decreased kidney and liver function, which changes the way our bodies metabolize drugs. A smaller dose of a drug may have the same therapeutic effect as a larger dose did when we were younger. If we did not adjust that dose and continue on our larger dose, the likelihood of an adverse drug event increases. We also have changes in our priorities. As we get older, quality may become more important than quantity. Primary prevention may no longer be a goal. The goal may shift more to reducing medication side effects. It's important to understand what matters to our patients and use that as a consideration in their medication management. There's also the opportunity to potentially reduce costs, as we know, as incomes become more fixed and the cost of medications continue to rise. Sometimes medication costs become a factor as well as overall healthcare costs. A challenge that we have in reducing medications is that our evidence-based healthcare system does not have a lot of studies and guidelines that include older adults. It's been more of a one-size-fits-all approach. Clinical drug trial participants are often not representative of an older population. However, some of our more recent treatment guidelines are beginning to take function, frailty, and autonomy status into consideration, and are allowing more flexibility in targets as we age. This change, even though it's being reflected in our guidelines, is taking a little bit longer to be adapted by our healthcare system. We're having a little bit of a hard time adjusting and realizing that our approach does need to vary. An example of this is hemoglobin A1C. Targets with diabetes are more relaxed in older adults with the focus more on trying to avoid hypoglycemic events. So we still want to have some control, but we also want to make sure that we're avoiding those hypoglycemic effects. The absolute lowest number may not necessarily be the best number. These targets are even more relaxed in those with multiple chronic illnesses and cognitive impairment. Here we're starting to see some flexibility in these guidelines, but we definitely need more studies specific to older adults, and it will take a little bit of time for the health profession to adjust to that as well. That's why we have movements, such as the 4M movement. With all this being said, there are opportunities to deprescribe or to reduce and eliminate medications. Let's look at some high-risk medication classes that contribute to polypharmacy and adverse drug events and present the opportunity for deprescribing. The first class of medications that we'll talk about are statins for reducing cholesterol and providing cardiovascular protection. We see decreasing benefit with increasing risks as we age. While effective for secondary prevention, the use of statins for primary prevention is uncertain, especially in older adults. Current guidelines from the ACC and AHA simply state that for those aged 75 and older, the decision on whether to use a statin needs to consider clinical assessment and the overall reduction of risk in treatment. We have supporting evidence from ALL-HAT study that also, in a secondary analysis, they found no benefit for primary prevention use of statins in those over age 65. Again, this proves quality over quantity and that balance of risk versus benefit with statins. Here's a polling question for you to consider. In older adults aged 75 and older, which of the following best describes the current guideline recommendations from the ACC and AHA regarding statin use for primary prevention of cardiovascular disease? A. Statins are strongly recommended for all patients regardless of risk. B. Statins should be avoided due to high risk of adverse events. C. The decision should consider clinical assessment and patient preferences, as benefits are uncertain. D. Statins are only recommended if the 10-year risk exceeds 20%. The correct answer is C. The decision should consider clinical assessment and patient preferences, as benefits are uncertain. This next class of medications that we're going to discuss is broad and a big challenge in geriatric care, and that is anticholinergics. Many medications have anticholinergic effects. This may be part of their actual therapeutic benefit or maybe an adverse effect. Either way, these all have risks and should all have big proceed with caution warnings associated with them, as risk versus benefit considerations need to be made. There's a wide variety of drug classes, as you can see here, that have anticholinergic effects, with antihistamines, antidepressants, antimuscarinics, antispasmodics, and so forth. We have a wide variety of medications that have different degrees of anticholinergic effects. Why are anticholinergics such a challenge? One red flag is that they have a side effect profile in older adults that can quickly result in prescribing cascades. These medications can cause dry mouth, dry eyes, constipation, urinary retention, elevated heart rate, and have CNS effects, including drowsiness, confusion, delirium, and memory loss. Anticholinergics can be a source of abnormal behaviors in older adults and need to be looked at closely as a potential root cause of these behaviors. There are lots of potential challenges. When we look at some of those side effects, we can see that they may be confused with other conditions and result in those additional medications that are being prescribed simply to treat the side effect of the anticholinergic medication. Notice another challenge with anticholinergics. With urinary incontinence, there are medications to treat incontinence, and they have anticholinergic properties, which are directly at odds with the cholinergic treatments that are used for those with dementia. So you have those two competing against each other, and in a dementia patient, those anticholinergics can really exacerbate the individual's dementia, accelerate it, and lead to those additional behaviors as well. In situations like these, there might be non-pharmacologic alternatives that need to be considered. Another red flag type of drug class in older adults are benzodiazepines. The American Geriatric Society advises against using benzodiazepines in older adults, but they continue to be massively prescribed to this group that have the highest risk for serious adverse events from these medications. Benzodiazepines are prescribed to help with a variety of conditions, such as anxiety, insomnia, and restless leg syndrome. They're sometimes used as a muscle relaxant. However, they have serious side effects and warrant strong consideration of risk versus benefit. When starting or continuing therapy, a lot of benzodiazepines are prescribed in the primary care setting. Up to 8% of the population might be prescribed a benzodiazepine. There are lots of bad things that can happen in older adults with benzodiazepines. Falls, amnesia, dementia, impaired driving, hip fractures related to those falls, and dependency is a big thing. This is one of those things where once you start on something, it can be a challenge to get off it. Loss of REM sleep is another factor. Even though benzodiazepines might be used to treat insomnia, the quality of the sleep might not be there. When we look at a dependency in benzodiazepines, and when we're trying to taper someone off them, it's important to do gradual dose reductions or a slow taper. Some recommendations are no more than 25% decrease every couple of weeks. Depending upon the dose that someone's at, it might take some time for that to occur. We need to have discussion with patients and families to address the risk and benefits so that they understand what's happening with these meds. When we do our dose reduction, share how there could be some bumps in the road, how we plan to manage any withdrawal symptoms, discuss treatment options and alternatives outside of benzodiazepines, and what we can do moving forward instead of having to rely on a benzodiazepine. Another class of medications that are troublesome in our older adults are antipsychotics, which are often used to manage problematic behaviors. These are similar to benzodiazepines. Our anticholinergics are red flag medications where risks often outweigh the benefit. The challenge with antipsychotics is that they are used more for off-label indications rather than what they were initially approved for. This is not bad in and of itself, as many of the medications we use over time develop off-label uses. The challenge with off-label use is that we have unintended consequences that are not identified during clinical trials, since off-label did not have a clinical trial performed. The biggest off-label use for antipsychotics is for behavioral and psychological symptoms of dementia. However, even though they're commonly used for this, studies have demonstrated only 11% effectiveness with antipsychotics in managing dementia-related agitation. This brings us to a situation of polypharmacy, where a medication, such as an anticholinergic, might be started to treat some behaviors. It's not effective, yet we never discontinue it. We just continue with that and add more onto that. That is one of the challenges we have with antipsychotics. In addition to that, we also see adverse effects, such as increased mortality. Having a black box warning and a higher fall risk, antipsychotics also can cause tardive dyskinesia, which can result in additional adverse events and further polypharmacy. There is a lot to consider with antipsychotics. There are alternatives to these medications, and a lot of this involves having an individualized approach utilizing non-pharmacologic interventions. Identification of the causes of the behavior is a key. Some of these examples include distracting and diverting. A good example of that is music therapy. Music therapy is often used to help someone that is having these behaviors. There's the empirical treatment for pain. Pain is often an underlying cause of a behavior. Our older adults, especially those with dementia, have a harder time expressing when they're experiencing pain. If someone is having behaviors, give them some Tylenol and see if that helps to resolve the behavior. There's also opportunities to go with the flow and to use positive body language. Don't try to argue with a person. If they're living in a mental state of 40 years ago, you need to try and relate to their experiences from 40 years ago. That goes along with not trying to rationalize with them on these things. It's not the easiest approach, but that individualized approach, taking what matters into consideration, can help look for alternatives with antipsychotics.